Thank you so much for joining us today. For our viewers, my name is Misty Seidenburg. I'm the VP of Clinical Programs for Upstream Rehab, a large multi-site outpatient company. Joining me today is Zach Rambo. He is a physical therapist down in Texas. I had Keri Rogers, who is also a physical therapist located in the Atlanta, Georgia area. And then Darin Payne coming with us out of Tennessee. So I really appreciate you joining us today. Looking forward to talking a little bit about fall prevention as we happen to be in National Fall Prevention Month, and Fall Prevention Week is coming up hot here. So to get started, I think, when I think about falls and my experience in patient care, sometimes that means different things to a PT versus a patient. Can you speak a little bit to how you would define a fall and really what fall risk means to you?
Yeah, sure. So when patients come in, a lot of times they think that a fall is just any time that they hit the ground. When we start really talking to patients that we may suspect that are at a high fall risk, they tend to be like, yeah, I find myself walking down the hallway, holding onto the walls, holding onto furniture, or I stumble and I trip and I catch myself on this. All of those things I still consider falls, which I think most of us as PTs do consider that a fall, because we know that it's really a loss of balance that we're looking at there. And if they don't have some sort of external device, be it a cane or walker or something to grab onto, they're going to hit the ground regardless. So educating the patients on, hey, yeah, those are actually still considered falls. Just because we didn't hit the ground doesn't mean that we're not at risk for getting injured. We know a lot of the research with falls on, they break a hip, they break the radius, do those types of things, and the increased mortality rate that comes along with those. And so that's kind of an important thing to instill with these patients, and be like, hey, we may be just bumping into walls now, but the next one we may not be so lucky. So we need to work on that pretty quickly.
I was just going to add, I talk with them about any near falls. Are you tripping? Are you stumbling? Are you, dizzy to where you feel like you are about to fall? Anything like that is something that I bring up with them as well in our conversations in the clinic.
Keri, anything that you want to add to that?
I would just say similar, I'll echo what was said. I think we're really looking at loss of balance, and we'll probably continue to discuss this more, but when you think kind of holistically about a whole person and impairments that lead to loss of balance and falls, there's definitely things that we can address on multiple fronts. And so kind of to echo what both Zach and Darin said, do they have dizziness? Are they unsteady? Do they have something secondary that's affecting their balance, like diabetic neuropathy? Do they have weak hip flexor strength, so they're not picking up their feet, they're not clearing the ground? And so as therapists, we know that there's so many things that can affect balance and that can create the potential for fall risk, and to Zach's point, potential for maybe even injury, which we also want to avoid. But I do think that for most patients, if you just say, have you had falls, or when they answer paperwork that asks if they've had falls, they're thinking of probably going to the ground, which, we want to be concerned about their safety and their function in a much broader context.
I think that's a really great point in, when a patient's had an individual has had a fall and whether or not they think that's problematic or not. But what other things are you all looking for? Maybe somebody hasn't had a fall yet, but I think you've alluded to some of these things, but what are the other factors that you are just assessing for in a clinic to determine if somebody might be beneficial for a fall prevention program?
I think one big one for me is obviously previous falls, and then that tends to spiral, or they know somebody who's fallen and they become very fearful. Like if somebody is fearful of falling, automatically all of their movements become guarded, they become less confident, and so they don't maybe get out into the community they don't want to exercise, because they feel like if they get up and move, they're going to fall. So for me, talking about the fear avoidance of of falling itself is an important one to answer your question there.
Something else that I really look
that.
at too, with I have a older population that comes to my clinic. Polypharmacy is also something that we need to be on the lookout for with a lot of these patients. Many times do they come in and they're on 2 or 3 different blood pressure medications, or they're on a diuretic and this and that, and we're starting to talk about hydration levels and all those types of things that all of a sudden, I'm calling their primary care physician because he doesn't even know that they're taking these different meds because they've been referred out so many different times as we've become more of this, specialized medicine culture where everybody refers out to the next person that's a specialist in this. So they've got, a kidney doc, internist, cardiac, and then their primary, and then, they're on 3 ACE inhibitors and a beta blocker, and they go, I don't know why I'm falling and passing out. Well, we're in the unique position where we can be that linchpin to kind of look at the person as a whole, as kind of Keri said, a more holistic look at that, and then bring in the aspects of, okay, do we have a diabetic peripheral neuropathy? Are we having polypharmacy issues? Are we having blood pressure issues? I deal a lot with vertigo in older populations too with the BPPV. Is it really that, or is it something else that's going on there? So making sure we have a good, thorough screen on these patients, and then really informing them, kind of like Darin says, with the fear of falling. Hey, we don't need to be afraid of falling. We just need to know how to kind of handle it, and we need to know how to progress and how to get away from why we feel that way.
It's a really, really good point of looking at the multifactorial components of falls, and that it's not just that somatosensory input, right? It's not just weakness. There's all these other things that can contribute. So I think that's a really valuable point for our other clinicians to recognize. So I know sometimes patients can come in and we identify a fall risk. Maybe they're referred to something else, right? They come in for low back pain and then we identify, it sounds like something else is going on. But when you think of this population as a whole, these individuals at risk for falls, what are you all doing in your clinics and your regions to impact this population and really provide access to people to even know if they're at risk for falls?
We do a lot of community outreach. I'm lucky that I have some patients that have networked into assisted living facilities and things along those lines, or that they liked us to come out and do fall screenings for their residents. Or we do, I have a wellness fair coming up that I go and I do fall screenings there. And then also getting along with, your primary care physicians, your internists, those people that are going to be seeing those populations that may be at more of a high risk for falls, getting them to start identifying those things. Because we all know that the doctors get super focused on whatever the issue is that the patient comes in for. And don't always take that step back to be like, okay, maybe there's another underlying thing. Also, on top of that, pretty much every patient that comes in for me, unless it's a post-op something or another, we're doing some falls or some balance and fall prevention stuff with them anyways, because everybody can benefit from that. And that's kind of one of our charges from APTA and from Medicare. Hey, let's keep these patients out of the hospital due to falls. Let's work on that.
Yeah, I was going to say something similar. I have a good relationship with the people that run our senior center in our community, and I've gone a couple of times and just given a like a talk, I guess, about these are some of the things that are happening. These are some of the risk factors. If you have any of these problems, come and talk to me after, or here's my card, and let's just chat about it and see if you need an actual screening, or if this is just something that we can take care of with just some advice, like removing your rugs, or hey, let's get you an appropriate assistive device. So having good relationships that can start. This actually started because she was the spouse of a patient, and she would come in and notice we were doing some stuff, and she's like, hey, do you think that would be something you could come and talk to us about? And they're all the time looking for things to do for their seniors. And so that's just a great way of getting involved with your local organizations like your senior center or a skilled nursing facility or something like that.
Do any of you do screens in your clinics, like have patients come in? How do you I think it's great getting out there in the community, meeting people where they're at. But I also recognize, at least for us on this call, busy outpatient therapists, how do you manage that in your day to day if you have someone call in and say, hey, I'm a little concerned about falling, can you screen me? How are you managing that into your day?
So we're lucky enough to have at most of our clinics Raintree, which has that. There is a screening tag for appointments types on that we do use for fall risk screenings, and that kind of I treat it just like a patient, in all honesty. So I find a spot on there that isn't super busy. I know that these screenings are only going to take me about 15 minutes to probably get through 30 minutes if the patient's super talkative. But I kind of make it a priority because I know a lot of this time we can kind of spin that, if they really need it, we can spin that into an eval, or we can spin that into, future compliance with the patient on bringing them into our clinic. And so just utilizing the tools that we have, using the fall template that we have through the screenings, and using the fall template that we have through the initial evaluations, I've trained kind of my office coordinator on, hey, if these patients call up or we get an online submission for this kind of stuff, let's get them in, let's put them on there. All of my clinicians are trained on how to do fall screenings. And we just try to make it our priority to get these patients in and seen, and then figure out if we need to triage them and refer them out, or if it's something that maybe we can go ahead and get started on pretty quick. And we just go from there.
Excellent. Can any of you speak a little bit more to those screens? So when we think about effective assessment tools, like what is the best mechanism in order for us to really identify fall risk? What are those tests and measures that our clinicians should be thinking about doing to really identify, is this person someone who needs physical therapy? Do they need maybe just more of a community-based intervention? Or listen, can they just come back and see us in a year and get that regular assessment?
Go ahead, Zach, you're on a roll.
So with those, we're going to do, 5 times 30 seconds sit to stand. We're going to do a tug. We're going to do single leg balance. Sometimes I'll throw in either like a Romberg or a sharpened Romberg to kind of take a look at that. And then also just trying to get a decent subjective about, like, hey, when does this patient feel like they're going to fall? Do they feel like they're going to fall? Or are they just here because somebody said that they need to be here? Because that happens sometimes too. Also, we've got some other tech that we can use to help with balance screenings and things along that line that give us a little bit more finite feedback on that. But it's really just back down to the basics. And when in doubt, go with your gut feeling. If you're sitting there and you see somebody come in and you're like, man, they're super unstable. Everybody knows that feeling. You see the patient that walks in and you're like, you get your breath catches a little bit as they try to open the door, and you're like, oh man, they probably need to be here. They're probably in the right spot. So when in doubt, go with your gut feeling, but don't forget the basics. We've got good research to support 30-second sit to stands. We've got good research to support tugs, taking blood pressure, looking at all that kind of stuff. If it needs to be an eval, then we're going to dive more into some of the comorbidities, risk factors, medications, things along those lines. But for the most part, it's just back to the basics.
I was going to say, I think it's important to remember that we are all in this profession pretty uniquely qualified to be able to do this stuff. Like Zach was saying, we go back to the stuff that we learned, day one or semester one of PT school, patient care principles. And our background is unique in that we are uniquely qualified to be able to do this. And then, like was mentioned earlier too, with the template that is in Raintree, even if you don't feel very confident, it's pretty clear and laid out of what you can check. And you can follow that template and you can come up with a good idea of, yeah, you maybe need to do something about this, or no, actually you're doing fine. Let's give you X, Y, and Z to do at home, and I don't think you need anything formal, but let's just work on this. So even if you're intimidated or afraid, we have the tools. We just got to remember to use them.
Yeah, and I would just add, looking at utilizing the study algorithm. So in sort of this discussion that we're having, we're really looking to stratify our patients as well for their fall risk. So we do have templates and things that we can use, some standardized dynamic balance testing, also looking at some of the other factors we've already discussed, like perhaps neurologic status, vestibular involvement, medications, or general health status, looking at vitals, looking at lower quarter strength, all of those things, but really looking to stratify our patients into low, moderate, or high fall risk, because that might determine their that does determine the intervention. So whether somebody is low risk, and then we can just see them for an annual follow-up, or that they know that if things were to progress, that they could call us, but we've started engage them in that relationship. Those individuals who fall into more of a moderate risk category, we can treat with appropriate exercises, addressing the dynamic balance components, addressing strength training, addressing perhaps the vestibular system or whatever other impairments we find, working on things, progressing into things like dual task, a progression of functional activities to address their limitations, or then those that are, high fall risk that maybe need even more intervention. Also looking to, I think this was brought up, but looking at somebody who's low or possibly moderate risk at, if we're involved in our communities and know what community resources are, we can perhaps refer them to, some kind of like community exercise class or something that would benefit them, but perhaps they don't need skilled intervention.
That's really great. I think we've all on this call talked a little bit about what we're doing to reach people within their communities and providing access if they come in to our clinics. But if you think about fall risk and fall prevention from more of a systemic issue, so we know that the rates of falls have not declined, right? They continue to climb. What do you think our role as physical therapists is, or should be, can be, in managing that from more of a systems issue? What do you think our role is?
I think Zach mentioned this earlier, but I think really being a general advocate, both for our prospective patients and for the elderly population, but also for what our profession, Darin spoke to this as well, what our profession can offer. So I even think when we're out, we get opportunities to meet with doctors, and whether that is primary care physicians, internalists, is not just generally saying, oh yeah, we work on balance, right? That's a very generalized statement, but to really promote sort of what I was just speaking to, but what we can do, how we can actually look at an individual and have tools, validated tools to stratify fall risk. I love something Zach said earlier, but there is a lot of evidence that suggests that unfortunately, if an individual does have a fall, and injures themselves, like breaks their femur, that it can even increase mortality. So we're really thinking about, systemically improving quality of life for advancing, for aging. There is so much that we can offer to treat our patients, not just, to say, yes, there's decline across systems with aging, but how do we improve quality of life for individuals, and how do we really reduce some of those risks that also have implications on the healthcare system as a whole, right? When people are requiring surgeries and hospital stays potentially, and how do we sort of manage that? And I think as physical therapists, we have actually quite a large role in that we should be able to advocate to other healthcare professionals as well.
I agree 100%. I think, again, like I said, we're pretty uniquely placed in this realm and with our training to be able to do this. We have the ability to look at medications, and we have the ability to know about some possible drug interactions. We obviously know how to assess and test the cardiovascular system. We know how to assess and test the vestibular system, right? Like, why wouldn't somebody want to come and see a physical therapist for these types of things, rather than having to go through the whole loop that we know of. Let's go see our primary care provider, then let's refer you to a neurologist, let's refer you, oh, that's not the right place, let's take you to the ENT, then let's go do this. It'd be great just to be able to establish, hey, this is the place to go, and you'll be able to get taken care of by seeing a PT for this, because they can do those certain things. And then at the same time, the flip side of that is we have to know our limitations. We have to know when it's time to refer out to somebody that has a little more background and things that we should, if we're seeing some red or yellow flags. It's responsibility we have as a profession.
I think that's really valuable, being able to put it out there. I would go even so far as to say, we know there are several legislative bills in action right now that, we in our healthcare profession, the roles we serve, can certainly reach out to representatives for as well and let our voices be heard. The more voices, the more powerful, I believe, and really helping our seniors get some access to this. I want to really thank you guys for hopping on with me today. I really appreciate the conversation. This is a great intro and avenue into talking about fall risk. I'm looking forward to maybe hosting a part 2 and talking a little bit more about some evidence-based interventions and what do we do with these folks that we identify they're at risk, and how do we take really, really great and excellent care of them to minimize that risk and keep them independent. So I look forward to speaking with you guys again. And again, just thank you so much, and we'll talk soon.
You're welcome. Thank you.
Thanks, Misty.
Thank you.